kind of a sort of a rotating talk that we do once every so often. And it's a little bit different from our, usual talks that we do in this Medications for Opioid Use Disorder ECHO program, because this one doesn't really focus on medications for opioid use disorder, right? This is a little bit more upstream, the talk today, and really focusing on patients with chronic pain who might be treated with opioids. Sort of like responsible opioid prescribing, screening and monitoring is really what we're talking about here today. Because I think it's an important topic that certainly comes up, right? And this comes up in cases, patients with chronic pain, how do we best manage them? If we're going to prescribe opioids, how do we do so appropriately, responsibly? This is something that comes up a lot. So it's just one of these one-off topics that we're doing. And as I begin, I have no disclosures, no financial disclosures to make regarding this. And we're going to start, I'm going to go right into it. Starting with, the question of what does responsible opioid prescribing look like, right? What is opioid risk management? When we're talking about opioids being prescribed in a chronic pain setting, I do think that responsible opioid prescribing is possible. And I think these are the components of it, and we'll try to touch upon all of them. I think to be able to prescribe opioids responsibly, first we have to become familiar with individual risk factors for opioid use, opioid abuse, opioid misuse. What are the factors someone already comes with? Using risk assessment tools. There are actually validated risk assessment tools, which should be part of the thorough overall evaluation. And if opioids are prescribed in a chronic pain setting, ongoing monitoring for what are called aberrant behaviors is, I think, the third major piece. And I think if we accomplish all of this, we're taking big steps towards responsible opioid prescribing. So I begin with the definition of addiction by ASAM, which is American Society of Addiction Medicine. ASAM defines addiction as a primary chronic disease of brain reward, motivation, memory, and related circuitry. We know, and we talk about this in other talks, right? In this series, that we've known for a long time that substance use disorders are chronic diseases that really affect the brain, the neurobiology of human beings in a profound way. And when some of these dysfunctions set in a vulnerable individual, that substance comes to be seen as not just being important, but being necessary for survival, right? And that's really the trickiness of substance use disorder, where a person comes to see that substance as being necessary for survival. And it has manifestations that go well beyond biological. It affects someone's psyche, their mind, their social relationships, has spiritual manifestations, and it really impacts the whole person and others around them. And ultimately, the individual comes to pursue that substance, even at the sacrifice of everything else. And something that no doubt many of us are familiar with, whether from just being clinicians or being community members, family members, or perhaps for some even with lived experience, right? And another term I really want to define. So one point I want to make with addiction, substance use disorder, the way ASAM defines it, is different from physiologic dependence. That's a term that comes up often, and I think it's important to make that definition, is that physiologic dependence is someone just getting used to a medication. Happens to many medications, right? So if I were to see Dr. Jacobson and maybe she prescribed me, a laxative, a stimulant laxative, if I took that chronically, my body would get used to that laxative. And if I stopped it suddenly, I would have trouble having a bowel movement without that laxative. That's physiologic dependence. Doesn't just happen to opioids, happens to many things. And again, that's very different from addiction, right? Substance use disorder, where there are cravings, there are consequences, there's compulsive use despite those consequences, there's inability to cut down, and ultimately this profound impact on the whole person. Another definition important to make is aberrant behaviors. I've already used it once. Aberrant behavior is any behavior that suggests prescription misuse, abuse, or addiction. So if opioids are being prescribed, monitoring for aberrant behaviors, according to CDC, is critical. And I've included this quote from Fishbane because I think this quote, although it's several years old, really tells us a lot of what we know about aberrant behaviors. So I'm going to read it, and the next few slides will hopefully break that down a little bit. Prescribing opioids will lead to abuse or addiction in a small percentage of chronic pain patients, but a larger percentage will demonstrate aberrant drug-related behaviors and illicit drug use. These percentages appear to be much less if chronic pain patients are pre-selected for the absence of a current or past history of alcohol or illicit drug use or abuse or addiction. This quote holds true even now in 2022, although it's at least 15 years old. So let's break this down. So how common is addiction, right, in a chronic pain patient? So if you look at all the chronic pain patients who are prescribed opioids, roughly what percentage will develop opioid use disorder, the way we define it in the DSM, or the way ASAM defines it, the way I just shared it? Anyone want to guess? You can just chat in or speak up. What percentage of all chronic pain patients prescribed opioids will display or will meet criteria for opioid use disorder? Anyone feeling brave enough?
5%.
It says small percentage, so I'll go with 7.9999%.
That's very specific, Jeanette. Thank you, guys. So you guys are right, and that's key to, there's often this belief, right, that many people who are prescribed opioids become addicted to it. That's actually not true statistically. So there are a number of studies that were done. If you look at this big study done by Kevin Bowles here at UNM in 2015, was a big meta-analysis. And what they found was average rates of addiction, substance use disorder, or opioid use disorder in these patients was around 8 to 12%, so about 10%, right? This CDC data actually showed, patients with if you look at higher daily dose, actually right around where you said, right, Jeanette and Flavio, about 6% at higher doses, so dose dependent according to CDC. So the higher the dose of opioids prescribed to someone, the more likely they might be to develop an opioid use disorder. But the majority do not actually meet criteria, right? About 10%, which is often cited in literature, is this Bowles study. But average rates of problematic use, those aberrant drug-related behaviors, right, are much higher, about 20 to 30%. So that's the importance of monitoring for those aberrant behaviors, because that might be displayed by a quarter to about 30% of patients prescribed opioids. And if we monitor it, if we pick it up, hopefully we can prevent this progression to them developing an opioid use disorder. Right? And that's really been fairly consistent, and this one again showing about, this one, the key point is this one in this study, that for patients without substance use disorder, the rate of them developing an opioid use disorder was less than 1%. So by far the biggest risk factor to a person developing addiction to their prescribed opioids is having a personal history of a substance use disorder, not just opioid use disorder, but any substance use disorder. And if you pre-select those patients, the rate of substance use disorder is actually very, very low. There's this new idea in literature, really has come about over the last 4 years, called complex persistent dependence, which is really this about 20% of primary care population on long-term opioids. They usually have high pain interference, right? Pain really impacts their lives. They display those aberrant behaviors, which we'll go into here in a few slides. They over time build up these high doses. There is often a lot of psychiatric comorbidity present, depression, anxiety disorders. These patients are often unwilling or unable to taper opioids, despite functional deterioration. Their functioning doesn't improve. They keep escalating the doses of opioids and yet are unable to eventually decrease down those doses. And if you try to reduce the dose, opioid use disorder-like behaviors emerge. And that's about 20% of patients who are chronically on opioids. And that's really another way to look at it, right, is the triangle is all the patients with chronic pain. These are non-cancer related chronic pain who are prescribed opioids. A vast majority do well on them. They take them as prescribed. Their functionality improves. They don't display aberrant behaviors. Then about 20%, right, display that complex persistent dependence. And this tip of the iceberg, right? Maybe up to 10%, maybe less, about 6 to 10%, will develop compulsive use and meet criteria for opioid use disorder. So that's why we want to really intervene, not necessarily here, but in this region before we get here. That's really the idea. So remember, responsible opioid prescribing, first part is knowing those individual risk factors. And that's what this slide is looking at. Statistically, we're looking at, right, lifetime history of a substance use disorder, by far the biggest predictor of someone displaying aberrant behaviors. Other ones include psychiatric comorbidity, history of pre-adolescent sexual abuse, family history of substance abuse, history of legal problems, younger age, and increased functional impairment have all been correlated in studies with aberrant behaviors to prescribed opioids. And going forward, right? So I'm gonna come back to this slide, right? Let's go here. So remember, responsible opioid prescribing, one is knowing those risk factors, and that's what this slide is looking at. Now, second is using risk assessment tools that have been validated. So before prescribing opioids to a patient with chronic pain, according to CDC guidelines from 2016, and the ones that are, the more recent ones that are going to be officially published soon, one of these risk assessment tools should be used. They're all validated in different populations. These are all public domain. The one that we tend to use here at the University of New Mexico Pain Treatment Center is the SOAP-R. It's quite a comprehensive screen, 24 items, patient reported, but you can see that the sensitivity and specificity are quite high. The negative predictive value is high, but you can see that the positive predictive value is about 57%. And I'm going to come to that, right? Because we need to understand what these tools can do and cannot do for us, right? So keep in mind, right? Because with any of these risk assessment tools, what we really care about are these positive and negative predictive values. Because the point of them is we're trying to predict whether or not someone is going to misuse the prescribed opioids, right? So that's really where I think the importance is of all of these. And in general, all of these assessment tools have a very high negative predictive value. In other words, if someone scores low on them, if someone scores negatively on them, we can be relatively confident that the person is not going to misuse the prescribed opioids. But all of them have a low positive predictive value. In other words, if someone does score high on them, it does not mean that it's a foregone conclusion that this person will misuse the prescribed opioids. The risk goes higher, but you can see that it's still only about 57% positive predictive value. So there is still a good chance that they will not use the prescribed opioids. And that's important to keep in mind. There is also another risk assessment tool called the COM, stands for the Continuing Opioid Misuse Measure. And that's designed for patients who are already on opioids. So say I've seen Dr. Warwick and now he's gotten me started on opioids. Periodically, it's recommended about every 3 months or so, the COM should be administered because it's going to pick up on any aberrant behaviors I may be engaging in to opioids that are already prescribed to me. Again, these are public domain, included a couple of websites, but last I checked, which was within the last month actually, they were available. So again, CDC guidelines says their evidence is sparse, right? There are methodological problems, namely, they have a very low positive predictive value, right? And what groups are they tested on? These are often tested, certainly not, this is relevant to us in New Mexico, certainly, that they're generally not tested in American Indian, Alaska Native populations, for example, right? So I think that's another methodological problem. But so by themselves, we don't just rely on those, but as part of that overall assessment, as part of responsible opioid prescribing, this is something that should be done according to the CDC, right? So the spirit of how we use them is important. We don't use them to deprive patients of pain management, right? Opioid therapy, but to identify patients who are at risk for addiction. Should be done with informed consent, but with advisement that this is part of our assessment. And if we're not able to do this, we may not have enough information to prescribe opioids safely and appropriately. They should be used to help guide us to determine the frequency and intensity of monitoring as we treat them. and should be used to develop the most efficacious and safe treatment strategy. The SOAP are the next 3 slides I'm not going to go over, but they're there for reference. It actually comes with very specific recommendations. So if someone scores high, in other words, over 21, what should be done? If someone scores in the moderate range, 10 to 21, and if someone scores low. This is the easiest one because, again, the negative predictive value is high. So if someone scores low on the SOAP-R, less than 9, the risk of them ever misusing the prescribed opioids is actually quite low. So that's really the easy one, but these slides are there for reference. And third, once opioids are prescribed, we monitor for aberrant behaviors, right? That's the third piece of responsible opioid prescribing. We used to, right? Not all aberrant behaviors are created alike. So here what we've done is broken them down into sort of green, orange, and red aberrant behaviors, gradually going in severity. Some of the mild aberrant behaviors, right? Someone requesting higher dose or requesting a specific formulation. I think oftentimes as we talk to our patients, something we all should be doing anyway, we can easily resolve this. Even when I was in medical school, people often talked about if someone requests a specific formulation, get your antenna up, right? That they're trying to seek that medicine out. I don't think that's necessarily the case. There's really little evidence supporting it. And we've all seen those commercials on TV, right? Like, talk to your doctor about such and such medication. So maybe the patient just saw that commercial and is interested in the medicine, or maybe the patient has an uncle or an aunt or a parent or someone who takes that medicine has found it helpful. Right? So talk to your patient, and it may be quite benign. Someone requesting higher dose. It could be that maybe their pain generator has changed or has evolved. Maybe they're in more pain. Occasional loss of prescription. Occasional increase in dose without permission, right? Occasional being the word, and often talking to the patient, educating them, sharing your concerns, hearing their concerns is the appropriate therapeutic behavior to these mild aberrant behaviors. Now we start getting into some of the more concerning behaviors that might suggest that complex persistent dependence, the moderate behaviors. Someone saying, well, I'm sometimes taking that extra oxycodone at night because I'm just so wired from a long day at work and I'm anxious, or to help me sleep, right? Using it to treat symptoms other than what is prescribed for. Stockpiling prescriptions, significant energy spent assuring supply. Now we're going into some of that compulsion, which is a part of opioid use disorders. Multiple unsanctioned dose escalations, recurrent prescription losses. Decline in functioning, very important. If any treatment we're providing, if it's appropriate, we should see functioning improve. But if the functioning is declining, it's time really to address that with the patient. Maybe this is not the right course of action. Maybe we ought to be thinking about something else. And of course, concurrent use of illicit substances should be talked about. And now we start getting into the severe range, continual escalation of dose, seeking prescription from other providers or ER, stealing drugs, buying them off the street. And I think the ones in red letters are just so dangerous that these are the cases in which I would really think about immediately stopping the opioids and thinking about switching them to treatments for opioid use disorder, right? Immediately, including diverting or selling prescriptions, although you have to make sure that they actually have opioid use disorder in that case. And medications for OUD may not be appropriate, depending upon the patient. Forging prescriptions, injecting oral prescriptions, which is just so dangerous, right? That I certainly wouldn't feel comfortable continuing to prescribe the medications if this was going on. We always want to be balancing the risk benefits and involving the patient in that shared decision making. I think that's just so important, right? And if the cases are challenging, obtain early consultation. Use this echo to bring these cases up, right? That's why we're here to provide that online consultation. And as has been pointed out, we've got people from lots of professional backgrounds that we can talk about. I really like this slide by Alfred. It's from one of his books and presentations, that what we do as physicians, as providers, as clinicians, is asking, do the benefits of this treatment outweigh any side effects and risks of harm to the patient or the society? What we don't do is say, is the patient good or bad, or does the patient deserve the pain meds, or should they be punished or rewarded, or do we trust the patient, that those aren't right. I think this is really what we come to in medicine with any medication. I like this cartoon, right? I think these are nuanced discussion where patient must be involved, especially if they've been on opioids chronically, because there are harms to stopping the medicine suddenly, right? And we saw this epidemiologically, right, where we saw rates of prescription opioids related mortalities, ED visits go up in the early 2000s. Physicians started cutting off these opioid medications abruptly. And then what did we see? Patients dropped out of treatment. They already had physiologic dependence. They went into withdrawals and they turned to heroin. And then between sort of 2009 and 2013, we just saw this dramatic rise in heroin-related overdose mortalities. I don't think that was a coincidence. It happened because physicians just abruptly cut patients off, right? So we gotta make an individualized, nuanced decision. And this cartoon, I think captures it well, right? There's the provider with CDC guidelines, all the newspaper articles on overdose epidemic, right? Too many people are dying. The situation's out of control. I kind of thought they were helping you, but right now I have to stop your Lortab pills. And the patient sitting there going, what did I do? Right? I mean, this is kind of what we want to avoid, and we really want to weigh those harms and benefits because there are possible consequences, right, to tapering, especially tapering, stopping abruptly or tapering too aggressively, including polypharmacy, right, invasive procedures, medical and mental compromise, ending of that care, trusting provider-patient relationship, but also things like suicidal ideation, illicit drug seeking, and death. And there are two recent studies actually recently within the last 2 years showing exactly this. And this one from last year, suicide ideations and suicidal self-directed violence went up in this particular study after clinician-initiated opioid discontinuation among long-term opioid users. So we gotta balance the two, right? We gotta balance the risk and the benefit. And for that, the clinical interview and judgment, talking to the patient, understanding them is critical, right? And then the other part is there are many things that we can do that we talk about in other sessions. So I'm not gonna go into too much detail with these next few slides, but these are things we should be doing. If we're prescribing opioids, universal precautions should be taken that every patient is potentially at risk. But some patients may be at higher risk based upon their personal histories or other factors, right, that we've talked about. So we individualize treatment to maximize safety and effectiveness and minimize harm. And that's part of the discussion we have with our patients. They should know, why am I having you come in once a week for your medication, but there's that other patient who only comes in once a month? Well, it's because we know that based upon these factors, you might be at higher risk. And I want to make sure that I'm able to continue to treat you safely. And that's really why, I'm having you come in. We do this with all of our patients, making that universal so patients don't feel singled out. And the things we do to mitigate risk include things like opioid agreements, great communication tool, right? Right ahead. What are your expectations for me? What are my expectations for you? Ongoing assessment, as we've talked about, monitoring, urine toxicology, prescription monitoring programs, things we talk about in other sessions are all essential. Pill counts for those at high risk, right? And, just a lot of intensity, seeing them frequently, providing shorter scripts, perhaps involving other family members with consent, other providers for coordination of care, and certainly seeking consent are all important things. But really the key being that we don't want to further stigmatize our patients, right? So we want to manage this within a practitioner-patient relationship. And if you are seeing some of these aberrant behaviors, I think these are just some practical questions to ask the patient. Maybe the patient was confused about how to take the prescription, right? Maybe they thought if one pill helps me, maybe 5 pills will help me more. There could be some real reasons why a prescription ran out early, for example, right? Maybe the pain generator has changed. And these are the questions that we should ask ourselves as we assess this, right? How has the pain condition changed, right? Is there an undiagnosed psychiatric disorder that needs treatment? And have you followed and set limits and rules? And this is according to SAMHSA. All important things to consider before we act. Just last 3 slides and I'll end it here. One is that in case you see mild to moderate, those green or orange light aberrant behaviors, generally the accepted approach is to increase the frequency of visits, right? Seeing them more often, obtaining collateral, increasing frequency or sophistication of tox screening, and providing smaller quantity of opioids or other controlled substances. Generally, we recommend tapering opioids humanely if these moderate to severe aberrant behaviors continue, despite taking some of these early steps to curb those behaviors, to set limits, to provide holistic treatment, patient-centered treatment. If these behaviors continue, then maybe it's time to reevaluate the appropriateness, that risk-benefit of opioids. Generally, again, if you can carry out a humane long taper as you begin alternative approaches of managing the pain, for example, acceptance and commitment therapy or CBT or physical therapy or non-opioid medications while tapering opioids, that's a better approach. And as one of our other talks we actually do a talk on evidence-based opioid tapering. Don't abandon the patient. Remember that stopping opioids is not abandoning the patient. You can stop someone's opioids, you can taper someone's opioids, and still provide evidence-based and appropriate care, right? And I like this quote: the decision to taper opioids should be based on whether the benefits outweigh the harm. And that takes a lot of clinical judgment. It's individualized and nuanced, and we can't codify it with an arbitrary threshold. But there are some times where you will stop the opioids, where the immediate harm is so great. It's usually those things that I had written in red, right? And certainly these are the times when you may want to consult an addictions expert if you're seeing those aberrant behaviors, or a pain expert if it's a challenging pain condition, if there's a lot of comorbidity, if they might require interventions, for example. And really for some of these patients, when you talk about addictions expert, the other thing that this ECHO certainly aims to do is to make sure that if you're prescribing an opioid, right, if you're a provider who prescribes opioids, who treats patients with chronic pain, I think it makes a lot of sense to also be trained in and have experience prescribing buprenorphine. Certainly in case of opioid use disorder, but also you see those patients with complex persistent dependence, buprenorphine might actually be a really appropriate tool. And I think that's certainly something I encourage and many of us find benefit from. So I will stop here. These are some references and turn it over to you, Dr. Jacobson.